All right, good morning, everyone. Sorry for the delayed call to order. We are just have been waiting to get a quorum here. So we will go ahead and call to order at 9:08. Shelley, if we can do a roll call, please.
Alyssa Michael.
Here.
Andrew Tang. Brent Forget.
Present.
Brian Steven. Charles Hu.
Present.
Clifford Jones. Damien Johnson. David Latrica. Esther Bissonette. Edgar, if you can come off mute, please. Or type in the chat. Horace Taylor.
Present.
Bronco Castro Marin. Gail Bradley.
Present.
Darth Gamer.
Present.
Herman Butler. We got you. Iman Pfeiffer. Jordan Weinberg.
Very competitive South.
Nick L.
Present.
Zane Kelly.
Present.
Ryan Southworth.
Here.
Sandy Nygaard. Colin Belchers.
Present.
Judy Bennett. At 14, we have quorum.
Thank you very much. Before we go into the body of the meeting, I just wanted to first take a moment of silence for the two line of duty deaths of the timber-based firefighters that tragically died earlier this week. So I wanted to take a moment of silence in honor of them and also the air crew that were involved in the fatal accident last month in northern Arizona as well. Thank you. Just a reminder for the meeting minutes, everything that is said as part of this meeting is recorded and posted to the Bureau's YouTube website. So if you have anything that is on camera or in the chat that is part of the permanent recording, we do have the attendance report that is on your roster. Just a reminder, if you missed 2 or more consecutive meetings, the Bureau will reach out to you to see if you'd like to remain active and on the committee. We do fortunately have quite a few people that would like to be involved. So we will reach out to you if there's any attendance issues. I would like to welcome again Dr. Hu, who has been reappointed to State Trauma Advisory Board. In terms of vacancies, we have 2 current vacancies. One is a representative from a statewide rehabilitation facility, and the second is a representative from an urban advanced life basic support hospital that is not a trauma center. So I think that is the key piece, not a trauma center. We are looking for a statewide rehab facility rep for quite some time that has been open, I think, for well over a year. But in terms of the non-trauma center based hospital representative, that is a newer opening. So if you are interested, please reach out to Shelley Bissell. Her information is on the agenda and she can forward your information on to the director. In your meeting packet, there is a 2026 meeting schedule. So that is available with all the meetings for the upcoming year on there. We have done our best to ensure that there is not overlap with any major conferences or other events. If you see something that is significant, please let us know. But we have done our best to try to avoid any big conflicts with the meeting cycle. For Bureau report, that is again an attachment in your meeting packet. I will just go over some of the items on here. Nicole is not able to join us today as she is doing her civic duty as a jury duty member. So she is not able to join us today because of that. So General update. One thing I just want to point out, the bureau chief role is still currently vacant. Anyone who has noted, we don't have fifth floor offices any longer. There is no longer definitive staff here. If you would like an appointment to come in for any reason, there's an option on the contact us link on here, or you can call and leave a message or speak to someone to set up an appointment. For any in-person business, you do need an appointment for that. So sometimes people have questions regarding certification, applications, things that they would like to drop off. If you would like to do that, that just needs an appointment done with us. One reminder we're trying to put out to everyone is regards to certification. We have seen an uptick in individuals with expired state certifications. A reminder that you have to have a state certification in Arizona to work as an EMCP. I think just with things changing over time, we've seen a significant increase in the number of individuals who have had expired certifications and have been working. So just a reminder to your personnel to have them kind of track their cert cards, and as an agency as well. It does, if you're a CON holder, affect some of the billing issues if people have expired cert. So that could be a big issue for you. There's quite a bit of information about trauma center review upcoming changes. I will not read that for everyone, but that is in the packet as well. The process for those of you who very thankfully do participate as trauma center reviewers as well. The strategic plan that was reviewed and approved just about a year ago. It has now been officially approved by the governor's office. So we're really excited about that. And that is now posted to the Bureau's website as well. For services section update, the data quality assurance, there's updated EMS dashboard that includes 2024 data. We will go over today the state trauma data for the year. EMS for children, we actually just did announce the new member and lead for that role. Savannah, who is going to be taking over that effective immediately. And naloxone leave behind, and we can open the map while I go over this. A big thank you to all the agencies participating. I did ask if they could put together a map just showing across Arizona where we have kind of agencies participating in this process. So we have 66 agencies currently within the state of Arizona. We have over 4,600 EMTPs that are trained. We have given out over 1,800 kits that have actually been scanned, and out in the community, we have delivered 6,900 kits. So you can see a really nice kind of distribution across the state, both urban and rural, of agencies participating in the naloxone leave behind program. We are very excited that the SHARE program has officially transitioned. We have made two big transitions that have completed. The first is the hospital database, which transitioned from CEDAR, which was the old University of Arizona database, to a RedCap system, which is much more simplified and easy to use for the hospital. And that is in line with the CARES National Registry cardiac arrest data as well. And then what went live this week, which hopefully if you're on our Gov delivery, we've got an announcement with the shared dashboard. If we can click on that quickly, this is a statewide dashboard that has both 2023 and 2024 shared data. Really excited to see that. We are starting to work on agency specific reports and anticipate having those out really pretty soon here. So the big step is making sure that statewide reports were all there. If you can just maybe click on the summary there, you'll see here, and then the inclusion criteria page as well, at the left. And so really great step to do this. To give everyone an idea, we've never actually had a shared dashboard. These were always kind of statewide reports in a PDF format. The beauty of a dashboard online is that you can click on different elements and actually query and look at things specific to that. So really excited to have this go live, and a big thank you to the whole team within the Bureau that worked in that. Bothell, who will here and will go over the trauma data, but also obviously key person in developing the share reports, and Adam and Josie as well. So really big thank you to the team. This is a pretty monumental accomplishment for us. So thank you for that. If you are not currently receiving Bureau communication, there is a link on here on how to find Bureau communication and sign up for this. You are more than welcome to sign up for all ADHS communication, but you will get all public health notices. So if you would like to have specific to Bureau of EMS trauma system, just make sure that that is the section you are clicking on when you sign up for that. If you have any questions regarding certification or enforcement, I often get questions of who do I reach out to? Is there a phone number that I can call, or is there a specific email address? So we wanted to link those on here for you. You can see linked here, the website link, as well as a list of FAQs regarding both enforcement and certification, and then specific email addresses and phone numbers if you had any specific questions you'd like to reach out to regarding that. So This will be our new format for the Bureau report moving forward. So please provide feedback if you like this or have any suggestions or other items you would like us to cover. Moving on to our standing committee report, we will start with the CEPI report from Sean. Sean, are you online and able to give the report? So I will just cover the brief CEPI report. So the update was discussed in terms of the conversion from feeder to the RevTap system for share, also in line with the CARES, the national cardiac arrest data set. There was discussion as well about out-of-hospital cardiac arrest data elements in the Premier EMS agency program. And again, try to improve our data so that when we do provide those agency-specific reports, we have accurate data for your agencies. We had a group that looked at some heat data, and that is available as well on the ADHS website. And then we presented, or what thoughtful did present, the 2024 EMS data dashboard, again, updated for the most recent data with that. So that is the report for EPD. Sandy is not on the line, so I will cover education. All right. Next for education, the education committee completed and approved an RSI training. So for anyone who has an agency that does RSI, it is a really nicely put together training. Thank you, Matt Shaw, for participating and giving really good feedback for that training. So that is available and live on our website for agencies that do RSI. The group also approved another work group to focus on specifically the updating a training for children and youth with special health care needs. The acronym CYSHCN. I really want to make sure that this is available. So we are hoping to have that published later on this year. And then we also formed a work group to make training modules cover multiple different IB topics as part of the ASTR, with the goal to retire the very long, kind of outdated ASTR document that we have on the Bureau's website. Okay, if you have me read that. I'll keep going here. PMD. So PMD, we did approve and discuss multiple different items specific to maternal hypertension, preeclampsia, and eclampsia. These are going to MDT this afternoon for final review and approval. There was some discussion about updating the TXA drug profile, also amended the childbirth and trauma TTGs, just to clarify some of the TXA dosing. And those will all go to MDT again this afternoon for final approval. Next, your trauma program managers work group. Heather, are you on the line?
Yes, I am, Dr. Bradley. So for the trauma program managers work group, our next meeting will be October 3rd in Summit Healthcare in Sholo. We have an agenda planning meeting this week, and save the dates have already been sent out. So we're excited for our next meeting. They do a lot of good training and resources for our trauma community at these meetings.
Thank you. Next, Adam, can you give a cases update?
Yeah, good morning, everybody. Let's see. So we discussed pediatric drowning data as presented by Antonio Hernandez at the last PACES meeting. We have a couple of work groups. One is looking at the Red Book from the Department of Education, and the other one is looking at children and youth special healthcare needs for some training for our EMCTs. We had a presentation on high-risk perinatal program from Jessica Payne, and Keith Francis from Arizona Complete Health Crisis System gave a presentation at the last PACES meeting. And then I think next week is PEDS Transport Safety Week as a recognized item, just from our corner. Thank you.
Hi. Thank you, Adam. And next, we will move to the discussion and action item. If we can go ahead and project the meeting minutes from the last meeting. Can I get a motion to discuss and amend and approve the meeting minute?
So moved.
Thank you. This first from Dr. Gamer. Is there a second? Second. Brett, thank you. All right, we will scroll through those. Any recommended amendments? Hearing none, any opposed? Any abstention? All those in favor say aye.
Aye.
Aye. Thank you. Meeting minutes are approved. Next, I don't see Dr. Weinberg on the line, so we will go ahead and skip item B and move on to item B. Can I get a motion to discuss, amend, and approve the draft annual staff report?
So moved.
Thank you, Dr. Gamers. Can I get a second?
Second.
Thank you. Upward. So we will start with the introductory pages, which are in your package here. This is just kind of a big thank you to our State Trauma Advisory Board, as well as TEPI, who really review and take the input for a lot of the trauma data that is here. Big thank you to all of our trauma centers and all the work you do to enter the data into our trauma database. Really, we know it's a big workload for you, but it really creates a wonderful collection of data that we have here. In your packet, we included the report to the director, which does include also a link to our fall dashboard. The fall dashboard is something that was added as a request by this committee, really looking at the impact of ground level falls on patients, especially the elderly patient population. And we did highlight as well this year anticoagulation use and how that is affecting our trauma population. That was another request that we had from this committee, was looking at the overall numbers for anticoagulation use, and that is included as well. In your packet, there is the trauma snapshots, but what I would like to do is hand it over to Vaughn and have her review some of the data with us.
I know, but after I joined, it's like echo came. I didn't know what else.
It's from that.
So while Bob was pulling that up, I wanted to point out the numbers. So overall anticoagulation use for all ages of trauma patients was 18%. So just over 18%. When you look at our geriatric patients, the 65 and above, 35% of our trauma patients in the state of Arizona who are 65 and above are on anticoagulation. So really a very sizable number.
Good morning, everyone. Well, I am going to represent the trauma report. Along with, I will show you some of the things which is actually not available on the website, but I just wanted to show you the trend, which we can see it by year in each of the tabs, but I put together some few other tabs in the report right now to show you that how the trend looks when we see it in one graph, but we'll talk about that later on. So let's start with the demographic first. As usual, now we are seeing the same pattern, increase in the trauma rates over the years since 2017. What we are saying is the number has increased from 742 per 100,000 to 975. So it is, and these are the population-based rates. So it takes into account the increase in the population also. Rate-specific, American Indian or Alaska Native has the highest trauma rate, which with 1,400 trauma rate per 100,000 for 2024, which is way higher than the statewide, which is 975, followed by whites, then black, and then Hispanic, and then Asian. The pattern is very similar over the years. It has not changed. We see some decline in the American Indian populations over the years, but it is highest compared to any other races. Asian gender specific, we see a high rate among male compared to females, but when we look at the elderly population, we will see that the female is higher compared to male populations, and that is mainly because of our number of falls. County specific, again, La Paz and Gila County comes up like very high in terms of trauma rate compared to our urban counties, and as you see, the rural counties are darker compared to our Maricopa and Pima and Pinal. So it is again showing the same thing as, the urban is lower compared to rural area. Now, what you see over here is that we have county level, we have gender specific, age specific populations, and the 3 tabs, what actually it does is that they are very similar, but county level will give you, this is a statewide information, but if you select on any of the county, then it will filter it out for you for that particular county. So what it's telling me right now is that gender, male and female are a little bit higher among male than female, and the trauma mechanism fall is number 1 mechanism of injury, followed by MVT occupant, and then struck by against, which is an intentional injury, mainly, then MVT non-traffic, and then MVT motorcyclist. These are the top 5 mechanism of injury. Alcohol and drugs, we have 15% drug and 13% alcohol. We are seeing this shift from alcohol to drugs in now few years, that the trend for drug is going up and the alcohol is coming down.
So the one thing I wanted to point out that come up with that is alcohol is something that's easy to test in the trauma center from a blood draw. We are probably undercounting the impact of drug use in terms of our trauma patient population. In order to actually get a drug screen for the positive drug test, you need to have a urine sample. Many of the patients will not provide that, or will leave before they have provided that to the hospital. So when we look at actual incidence of drug involved trauma, I think this number is probably very underestimating the actual effect of that.
Quick question. What is categorized as a motorcycle? And I know we've talked about this before, but we're starting to see a lot of those e-scooters that move at high rates of speed. And are we capturing that?
So we are not capturing e-scooters separately, but they won't come under motorcycle. We can look at into detail of just pick those ICD-10 codes and figure it out how much e-scooters is increasing.
Okay, the e-scooters and e-bikes now.
Yeah, we can do that.
They're moving fast,
Yeah.
and we're seeing those. So.
And then there has been quite a bit of discussion at the national level of trying to figure out adding in specific codes for EMS to capture that as well. But I think that has not been adopted yet by BEMSTS, who kind of governs the overall national EMS data sets. Just recognizing, I think it's a big national trend, seeing more and more accidents involving they call them micro vehicles.
Is Carissa online? Carissa, if you want to talk about e-scooter, are we capturing separately, or we were talking about that?
Yeah, so I am the way that we could distinguish those is we capture the mechanism or the position in vehicle field, which is different than the ICD-10 codes, but we have a little bit more flexibility with the position in vehicle field. So we have been able to add in e-scooters and things like that. So if we wanted to look at that in the future, we can kind of break it down more using that field.
Definitely. And then I can look into the distribution, and if it is increasing, we can think about even creating a report for it. Yeah.
Just to kind of add on, Phoenix Children's Hospital Trauma Services parsing out the e-scooter or whatever you want to term them as a separate category. And I think we could urge our pediatric trauma centers to do the same. It's a good data set. And then the only other question I have is the effect of medicinal and recreational marijuana use. Is that in this, or is this kind of the same phenomena about?
It's the same phenomena, so it's just whether they can get a sample at the hospital. So, the blood draw is a standard thing. Everyone who comes in gets blood drawn with their ID. It's trauma patient. The urine test is easy to get around.
Mm-hmm.
Total hospital charges are $5 billion, and the median hospital charges have increased to now $40,000 for patients. One more thing we added, the new thing in the dashboard this year is trauma patients on anticoagulation medications. And if you see that 16% of trauma patients were on anticoagulation, and this information is really helpful for all patients. Want to add anything to that, Dr.
Yes. I think, when you look at the elderly patient population and kind of risk benefits and where can we potentially have some injury prevention, I think there's an opportunity for potentially our trauma centers to work with some of their geriatricians and cardiologists at really evaluating some of the elderly patients and the anticoagulation. What is the risk benefit ratio? If they're on anticoagulation for stroke prevention, but they have a ground level fall and have a catastrophic head bleed, what is kind of that risk benefit ratio? Because we really are seeing a significant increase in our elderly patients who are on anticoagulation, with significant trauma associated with that. Definitely that is one of the pieces that makes them a higher level trauma when they come into the hospital. And so potentially an opportunity for injury prevention, business forward.
So now, as I said that, county level information, we can now click on Coconino County and then it will tell us more information about Coconino County. So we can filter for any of the counties. So that's of each of the tab name. So for gender specific population, we can click on gender and it will show for male or show for female, what is happening in the state. And I don't want to spend much time because I want to talk about some new information that I want to show you guys. But age specific population, again, the same thing. We have two options available, pediatric populations and geriatric population. And so this, all the information what we saw that you can filter it out for particular specific population. We also have a level 1 trauma. So this filters out, this is only level 1 trauma incidence, which is like 51,000, and then it gives you information on the same information, but it is only specific for level 1 trauma section.
And this was another request, I think, from this committee, was to really separate out kind of all trauma centers when we have level 1, 3 to 4s, and saying, okay, let's look at our level 1 patient population as it is a different acuity versus our level 3 and 4 patients. One of the questions that I always like to clarify every time we review this, lots of probably laugh at the exact same question, is when you see really high rates in certain counties, we know that especially in our rural counties, many of these patients get transported out of that county to a trauma center in a different county. The incident of injury is where that trauma is counted. So it's not based on the facility of where that patient arrived. So if they are transported from Santa Cruz County to Pima County, but the accident happened in Santa Cruz County, that is where that trauma is attributed to, which then makes sense when you see some of these really high rates. So the darker red colors on the map are where the higher incident rates per population. So it kind of makes sense that you have these higher acuity patients in some of these rural areas. Then top 6 mechanisms of injury, and we can have, so right now we filtered out all by default, but we have top 6 available over here, and then we can choose MVT motorcyclist, and then it will change the information for the MVT motorcyclist. So these informations, again, going back to what Dr. Bradley said about the fall, we have the anticoagulation medication percent available, and that tells you like 30% of fall patients were on anticoagulation medication. So what I want to show you over here is that what I did over here is that you can see at the bottom that is it's a year, so from 2017 to 2024, and we saw that the mechanism of trauma numbers are increasing over the year, the trauma rates are increasing over the year, but is it true for each and every mechanism of injury or not? And that is what I wanted to show you, that we do have all these data on the dashboard, but when you see it, one injury at a time, and then we can see like, okay, fall, yes, definitely if you see the straight line, it's increasing over the year. But if I look at the motor vehicle occupant, look at that, that's kind of, coming to a plateau. So it's very good that, we are not now increasing. That dip you see is again a COVID, so just that year, everything, people staying home, and that's the reason that dip rate over there. MVT, on the other hand, MVT motorcyclists, you see that they are climbing over the years. Pedal cyclist is also climbing over the years. So this firearm, that's good news, is that it did increase quite a bit, and now we are seeing last 2 years there's a decline in the firearm numbers. So I just wanted to show you like the first page what we have under county level. It gives you the mechanism of injury. I can change this to any of the year, and it will give me the mechanism of injury, but this page is showing you, and this is not available on the website. I just want to show you what can be done with the trauma data, with the trauma report, the dashboard available, this information. This is something you can look at it. I think to your point, Brent, in terms of like looking at the e-scooters and e-bikes, that is something we can definitely look at. I'm sure there was probably 0 in 2017, and you see a steady increase over time. So that is something we can definitely look at moving forward to add in.
Yeah, I think we need to, just so we can start looking at prevention measures too. And communicate.
Question, are we able to look at data specifically by race to share that combination? And then several years ago, the Bureau designated American Trauma Report. Would love to see something like that again. Also, the opioid overdose and give here with some
Yeah,
distribution.
So I can, we already have updated 2024 data for race and ethnicity, and I can just show the dashboard, yeah. Then similarly, look at the age group. So it is the same kind of information, but by age group. And what we are saying, again, keep in mind that our trauma numbers are increasing. So if that means that each and every age group is affected, and the answer is over here. What tells me is no, is like what we see is like under the 0 to 14, it is kind of declining. 15 to 17, it's again going plateau. But mainly what we are seeing the increase is in its elderly populations, and that kind of makes sense is that falls are increasing. Then for the county, and again, I know we do have a county page. We can do the same thing. We can look at the same thing, but it is nice to see it, all together like this. Like, okay, which county is increasing or decreasing over the years? So Gila, we saw that has the highest trauma rate, but it was really very high in the year 2021. And even though it stays really high in 2024 also, it is kind of on a declining pattern. So that's a good news, but it is still one of the highest. Then the Gridley County, we are seeing some increase, like Maricopa is going up over the years, and Navajo County is really decreasing now over the years. So these are some of the, like Mojave. So even though the rural area is still higher than the urban, when we do it by year for each of the county, it shows that, many of the rural counties are going down. Like La Paz is going up, but many of the rural counties is going down. And that's our alcohol and drug, what I was saying. So what the first is that's the first line, the purple line is showing overall, whether either alcohol or drug, does not matter, some kind of intoxication was there. And that number is increasing from 22 to 23% to 24. And now, it's kind of in the 24, around quarter of the patient. But then what we see is the red is the alcohol, and then the down is the last is drug. And the alcohol, as I said, the train was going down. And then if you see over here now, the drug is kind of started going up from the alcohol over the years.
And I think that really matches a lot of the national data out there that the younger population is not using as much alcohol as they are some other illicit substances and recreational marijuana. So this does kind of follow that trend over the last few years. But very interesting to see our trauma data. I think if there was a way to truly capture all of the other illicit substances, one of the challenges we've talked about in this committee as well, specific to the fentanyl epidemic. Up until recently, many hospitals, you actually had to order a separate urine test to test for fentanyl. So if they got a standard drug screen, it wouldn't actually detect fentanyl. Plus, many of our trauma patients who have injuries may get fentanyl from EMS or at the hospital. That kind of clouds your urinalysis result. And when you actually try to figure out, is there a substance involved, we probably are, there's again that underestimation, but some limitations of gathering that data accurately.
So my main purpose of showing you guys these trends is, again, for the same purpose, we were talking about the e-scooter injuries, is to come up with some ideas for injury prevention programs. So, which age group is more affected, which county has what problem, which mechanism of injury is really causing, it's increasing over the years. Things like that, we can do it from our trauma data and can have a focused injury prevention program on in a particular age group, particular county, or ways, many other ways. So that's why I wanted to show you guys, some of the cool things we can do it with the dashboard available on our website. Then I also question going back to the race and ethnicity. I want to show you guys. I'm not going to go into the detail, but we do have the dashboards available for that. Let me open it up. This is on our website. That's our data visualization page. And see, we have actually multiple dashboards available, and there is a trauma injury by race and ethnicity. And that dashboard is, now we have a 2024 data also available in this dashboard. And this is where you can look at it, everything for American Indian, I mean, any ethnicity, we can look at it. So here we have an option for selecting maybe American Indian or Alaska Native, and then it will just give us all the information about county, age, and gender specific trauma rate. And then we can go to injury and care pattern. Again, we can select the particular race and ethnicity, select the year, and then we can look at it, what is happening in that population. So I'm not gonna go into details, but that dashboard is also available to filter by the race and ethnicity.
Do you want to show maybe the fall
Yeah.
dashboard as well?
Sure. Our fall is not yet updated.
Okay, I'll just finish it.
Okay, sure. So you want to talk about it?
Sure. So this is our fall data. We do have the 2024 data that is just ready for getting final approval to get published. This is something that again came out of this committee, really trying to evaluate fall, recognizing that there's two big buckets of fall. So our staff report is specific to patients who are transported to a trauma center. But we know that many ground level falls may end up at a non-trauma center very appropriately. So ground level fall with a hip injury, a hip fracture, head injury that doesn't meet trauma activation criteria. And so we have a very large patient population that ends up in a non-trauma center. We are able to capture those patients by combining the EMS data with hospital discharge database data. So it's a different bucket that we use to capture those patients. And so I do think it's interesting just to look at that. And we will have the 2024 dashboard we'll share in January, and we just shared earlier if that's live. But this does show you we have falls overall, so this includes non-trauma centers plus trauma centers. And when we look at severe fall, that section is specific to patients who are transported to a trauma center. We were asked to include patients who have a hip injury, and then also looking at specific of what type of fall. So, ground level fall versus fall from height, and the level of trauma center designation. So if you're looking for some fall specific data for any injury prevention programs with trauma centers, this is a great resource where you can get some of that data as well. So I just wanted to point that out there, that we do have that there. The 2024 data should be coming shortly.
Right. And then just one more update is that we have our motor vehicle traffic related trauma. The dashboard is also updated with 2024 data. And once we approve the staff report and everything, our annual report, trauma injury by year, we have on the website 2024 available.
Any questions or feedback on the staff report for Vauxhall?
That's great. Thank you.
Excellent. Great work. Thank you. Just a technical question. This goes to the interim director, October 1st.
So once approved here, this would go really after this meeting goes to the interim director, Sheila Schillender, and then once approved by her, then it would be posted on our website.
Okay. Do we ever, I noticed we have recommendations for future initiatives or state trauma advisory board recommendations. Do they ever opine on whether these are appropriate? Do they ever add to what they want the board to take up as issues? I'm just historically, I don't think that's ever really happened.
I don't think it has. No, I think it's really they look at this committee to add and kind of address things. And really we have we had the calls work group in 2024 that we had really looking at kind of developing fall specific data, gathering some resources for that. So I think this committee really does an excellent job of kind of advising Bureau in terms of what you want to look at from a trauma perspective. But if there are things that are not on here that the group would like to include as recommendations, we are more than happy to consider adding them there as well. What Dr. Gamer is referring to is page 8. Please add head injury to the fall data. We do have that. That is in the fall data already. We have head injury and also anticoagulations on there as well.
But not right now in that calculations. I will update even.
Yeah. The one thing to say about the anticoagulation, just as a limitation, we can get that for trauma center data because the trauma centers do record that. We cannot necessarily get that for patients that go to a non-trauma center because that is from the hospital discharge database. So many of those patients are not coded as having anticoagulation. So the anticoagulation use, I think, Sean, that's you signed in trauma services. Specific that it's going to undercount that number. So we would put a big disclaimer on the fall one for the general fall patient population. makes sense.
Just trying to anticipate what the global issue of the day or what they might ask, that we take a real hard look at the effect of fentanyl. But I think we could easily respond back with, and you eloquently explained it, that it's kind of tough to get a handle on what fentanyl had to do with a given incident, since EMS a lot of times will get fentanyl, and in the interest of humane treatment of patients, they get fentanyl before their diagnostic work. It's completely it's a lot of it's, because of the pain issues. So, I think we've got plenty to say. It's a hard target to hit, but we're pretty confident that it's a major issue out there.
Yeah, I think the two big pieces that we can really look at in terms of kind of newer injury prevention, out of the committee a couple of years ago, Boxel and the team really worked on looking at the off-road vehicle injuries, especially with pediatric patients. And some of the data that came out of that really resulted in legislation being passed at a statewide level requiring safety training, helmet use for pediatric patients on these vehicles. So I think sometimes we look at data and we think it's just data, but actually we can use the data to save lives. And that's the hope that we can do with it. I think the two big areas where there's an opportunity are the e-bike and the scooter, all the different devices that are out there that you see a lot of kids riding around on without helmets, going at pretty fast speed. I think that data is something we can really evaluate moving forward. And then also continue to look at the fall patient population and anticoagulation use. I think that's another big opportunity for injury prevention. Any further discussion or input?
Just out of curiosity, do we have an age breakdown for at least some of that drug and alcohol information? Is that possible to pull that out?
To do what, I'm sorry?
So the drug and alcohol, where you have basically, you see alcohol going down, you see drug use being more, just what is the breakdown of the ages between those things?
We can definitely see that. I mean, we have a age specific available information, the tab, but that has a pediatric and geriatric that combines. So we do does that. So and in that you can see the alcohol, but it's very easy to get that information because we do capture age and we do have alcohol, so we can get the chart.
I just think just that might be slightly interesting as far as pushing some policy or other programs. When people are actually enacting a program to try to institute change, like it's not just about naloxone and levine, which has been great and very successful. That's awesome. But it's where do you actually target people, and what age groups do we need to target to be able to get the biggest bang for our buck based on those things? Is it, just marijuana use that's really driving this? Is it fentanyl use? We think it's a lot of fentanyl, of course. But again, the data is blurry. So if we have a strong use between like 18 and 25-year-olds or something like that, college age, crowd, and you can target campuses, target other things. So it actually gives a little more granular data where they can create maybe a program that might make that needle move in the right direction a little bit more.
I'm also trying to do this real time for you.
Yeah.
We can definitely get the data. The short answer is absolutely.
Yeah, it's all there. Okay.
Yep, we have definitely also can pair out that data kind of in age brackets to get an idea of drug and alcohol use with different age demographics. So I've got that on our list for future reports as well.
I have it. Maybe I can show you.
Yeah, I think that
Yeah.
interesting too.
All right, so there is a motion on the floor to approve the staff report as drafted. Is there any recommended amendments to the staff report summary and recommendations? Hearing none, is there any opposed? Any abstention? All those in favor say aye. Thank you. All right, Dr. Weinberg, I did see that you joined us, not to put you on the spot, but wanted to see if you potentially had an update from the College of Surgeons.
Yes, sorry, I really tried to get there in person today, but it just wasn't going to happen. I can give a quick update. So since the last STAB meeting, there's been some changes in the Arizona Committee on Trauma Leadership specific to the vice chair positions. Dr. Andy Tang has completed his term as vice chair. And we have two new vice chairs that have been appointed, Dr. Colin Stewart from U of A Tucson and Dr. Scott Sholem from John C. Lincoln in Phoenix. And the other vice chairs are Natasha Carrick, Christina Colosimo, and Chris Knapp. Regarding trauma education, just want to remind everybody that the ATLS 11th edition launched this summer, and all ATLS instructors need to complete the online module to be credentialed to teach the 11th edition. And the other thing that's happening with education is the State Committee on Trauma Resident Paper Competition will be on October 10th in Tucson at the U of A. There are 10 residents from across the state, residents or fellows, competing in that competition, and the winner and possibly the second place winner will go on to the regional competition, which is going to be in San Diego sometime in December. With respect to quality improvement, something that's the Central COT is starting to push is involvement in the National Pediatric Readiness Project. And this is a national initiative that's led by Health Resources and Services Administration. And the idea is that it's a program that ensures that every emergency department across the country, whether they're a pediatric hospital or not, is prepared to care for children no matter where they live. And of course, pediatric readiness covers more than just trauma, but the COT is focusing on the emergency department's role in taking care of the injured child. So this is just starting to get rolled out. The idea is that COT will help promote best practices, tools, and strategies to strengthen pediatric trauma care across, for our purposes, across the state of Arizona. And Dr. Scott Sholem is going to be the COT state champion for pediatric readiness. So he's starting to sit in on the webinars, and there will be more to come on that over the next 6 to 12 months, I suspect. Lastly, just for advocacy, we have a state Stop the Bleed champion, which was formerly Dr. Colosimo, but now it's going to be Colin Stewart. So I mean, there's a lot of different ways to get Stop the Bleed training. It doesn't have to go through the COT, but often it does. So those requests that come through the COT get fielded to myself and Dr. Stewart, and we kind of divide up the greater Tucson area versus the valley and northward, and help the people requesting those courses get taken care of. Dr. Colosimo has really moved into the kind of advocacy lead for the state COT, and she's really working hard on getting support for AZ Senate Bill 1428, which is related to establishing a Stop the Bleed pilot program within AZDHS with the goal of providing public school training and Stop the Bleed kits across the state. So she'll be at the state capitol on the AZ-ACS day in January with a table set up there to help support that bill. And we have our national meeting in October, and I'll report back from that at our next staff meeting. Any questions for me? All right, thank you.
Thank you very much, Dr. Weinberg. Next on our items, we're going to review the draft annual report and operation plan. This will go to EMS Council next for review and approval. I want to highlight a few of the pages. This is a 42-page document. We will not go through all of it, but thank you to the 4 regional councils that provided their report. If we can maybe highlight the snapshot, visual snapshot. So this is Julia's handiwork, if I'm looking correctly. So if you look here, you see a kind of a summary of our C1 process, our ground ambulance services, Total numbers there, we have the total number of EMTs, to 22,921. So that is the number of EMTs in the state of Arizona, and just over 7,000 initial applications approved last year. The total number per category, you can see that we have just over 13,000 EMTs in the state, 8,300 paramedics, 182. I just realized that should be 8 EMTs. And then we have 6 I-99s left in the state. So this number slowly is dwindling down one by one each year. In Portugal, we have the number of cases opened in the last year, our number of air ambulance units. We have training centers. Looking to be interesting, we have 8 new training centers in the past year, so really a pretty big increase. And the grants that we currently have, you see listed here. We have our FR grant, which is what funds the naloxone leave behind. The EMSC federal grant funding, which is what funds our pediatric programs. And then the Governor's Office of Highway Safety as part of post-crash care. This is funding our new trauma platform for data as well. You can see in our AZ peers, we have 1.3 million plus records submitted to AZ peers. So really impressive. And then we had 6 dashboards, but I think we probably have more than that. We have really an amazing amount of data. If you are ever looking for data that you can use for grant applications, I know that the University of Arizona did use some of the data that was here, and we're able to get funded for very large grants to help support some post-crash care in Southern Arizona. So this data, if you need help of how to kind of localize or use some of it, please reach out to our team, but there's quite a bit available. You can see our base hospital, our trauma center numbers. We have our different types of illness and injuries, our naloxone leave behind data, our cardiac receiving and referral data, and then all of our recognition programs listed as well. And then a summary of our EMS and trauma, our annual reward that we start giving out in May of each year. I'm going to kind of scroll through, we won't go through all of this, but a very nice visual stoplight pattern, which kind of shows where we are with some of the strategic initiatives. So ones that we are on track, one that are in progress, and others that are on hold as of right now. Some of this has been pending approval of the governor's office. Yes, Damien.
Quick question before we dive into that. On the last page with regarding the training centers piece of it, is that data also available as far as where those are located, what regions they're covering to try and help? Because one of the things we're looking at on the back end, and I know it's been a problem for the entire healthcare industry itself, is workforce development, improvement and increase on that. So I was just curious about that. Seeing 8 new programs is great. Or 8 new training centers is amazing. Just be nice to be able to make that connection with the local folks do it there.
Absolutely. I know I had asked for, can we get a map of the naloxone leave behind, and less than 24 hours later, there's a map. So I guarantee you we can get a map of this for you. So yes. So that is great pickup. I think that it's nice to see as we see an increase, where is the geographic location of these? Is there an opportunity as we see some really large rural funding from the federal government? Knowing a lot of other healthcare funding is decreasing. There is quite a bit of funding coming out for rural healthcare initiatives. Is that an opportunity for that as well? So thank you for pointing that out, Damien. So we won't go through all of that component, but just want to point out we are still working on that, and that does fall under one of our strategic initiatives, which was workforce development and training. So that falls very well in line with that. So thank you for that suggestion. We have the operating fund and budgets that is listed and included in the packet. And then revenue and expenses included there as well. So we just wanted to make the group aware, like I said, we're not going to go through all 42 pages. We have some of this in your packet if you are looking for some of the bigger items for review. But once this is approved by EMS Council, this will be publicly available as well. We will keep scrolling if anyone sees anything specific they'd like us to cover. The next section is really just each of the 4 regional councils have provided their annual plan to us as well, which is outlined in that.
Does anyone have a draft in the room? You have extra draft.
There's currently a list of the training centers on the website, so it should be pretty easy to put that in the map form.
Okay, thank you. And next, we'll move on to any agenda items to be considered for the next meeting. that we are definitely always interested if there's any injury prevention program thought the group has. The fall work group is really very effective. That came out of that. So if the committee has any other ideas of things they would like us to address, we are more than happy to take those on. So please, you can email myself or Shelley Bissell, and we can discuss that and include that on this agenda. Next, call to the public. Hearing none. Upcoming events. There is a long list of upcoming events in the agenda, some of which start as early as later this month and then going into the rest of the end of the year. You'll see multiple different trauma events going on. And then you'll also see the Cardiac Arrest Survival Summit that is being held here in Phoenix. This is really a great opportunity to highlight all of the here and the work that Arizona has done in cardiac arrest resuscitation. So if you're interested, that is live and open. I know Dr. Gamer has been really plugging that with a lot of committees, trying to get EMS agencies out and being represented there. So a great opportunity for us to highlight the work we do here in Arizona.
Dr. Bradley.
Yes.
Just email me at gars.gamer@phoenix.gov if you have any questions about the Cardiac Arrest Survival Summit, how to register, how to get involved, the program, any questions whatsoever. I would urge, if you have interest, to go to the either the Citizen CPR Foundation, again, Citizen CPR Foundation website, or there's a Cardiac Arrest Survival Summit website that I think early registration goes away October 1st or in early October, but it's it's a bit pricey, but it's a long, very involved program with a lot of different breakout sessions. There's going to be new guidelines presented by the researchers themselves in a number of different resuscitative parts. So should be good. But questions, contact me, please. Thank you.
Thank you. Our next meeting will be January 15th, 2026 at 9 a.m. We will have both an in-person and virtual option. And if I can get a motion to adjourn, please.
So moved.
All right. Thank you very much.
Thank you, everybody.